Hi, guys. Uh, so I wanted to take you through Keith Simmons. This is the final part of this review. I'm going to go through the cases and what I asked you during the cases, which obviously reinforce important content. So we have Mr. Simmons, who's got congestive heart failure. He's got fluid in his lungs, abdomen, lower legs. Explain the mechanism of the appearance of these signs. So the effect on the kidneys is demonstrated here. We have a, a fall in mean arterial pressure with a decrease in cardiac output that increases sympathetic activity and initiates the barrel reflex, which tends to short-term maintain blood pressure. That sympathetic activity also activates the renin-angiotensin system, and that causes more vasoconstriction. It also ultimately causes release of aldosterone. You get sodium retention and water reabsorption in the kidneys, and that causes your blood volume to go up, and that increases the central venous pressure, the filling of the heart, the stroke volume, and the cardiac output. So it helps you to maintain mean arterial pressure. But remember that this increase in central venous pressure also increases capillary pressure. And if you increase capillary pressure, you get increased filtration relative to reabsorption, and that will cause edema. So the next question is, why does that edema happen in the lower legs and not in like the hands and the arms? And the reason is because of gravity. Gravity is pulling down on the columns of blood when you're standing up. They push down on your feet and the beds in your lower limbs. Now, remember, they're pushing down on, gravity is pulling blood down on both sides, on the arterial side and the venous side. So the pressure on both sides goes up the same amount. And so your change in pressure across the system, and therefore your flow, doesn't really change just because you stood up. But all the gross pressures go up. The pressure on the arterial side and the venous side goes up, and that means your capillary pressure goes up. So if you take a patient who's already got congestive heart failure, already got high venous pressure, is already retaining fluid with kidneys, and now you add the increased capillary pressure due to the fact that he or she simply stood up, you get more filtration relative to reabsorption, and that gives you lower leg edema, whereas in areas where gravity is not working as hard, let's say up closer to the heart where the hands are, you aren't as likely to see edema. Okay, so lower limb edema is really a good sign that you're dealing with congestive heart failure, and maybe not some of the other things that tend to cause edema, like kidney disease that you'll learn about later. Okay, and it's a particular sign of right-sided disease. Okay, and where does the operating point shift and why? Here's our normal vascular function curve. Here's our normal cardiac function curve. In a patient with heart failure, this is a decrease in inotropic state or a decrease in contractility. So we get parallel shifts downward in the cardiac function curve, less cardiac output, less stroke volume at the same degree of filling with each of these curves. And if the heart failure is severe, then we'll drop down to the lowest curve, okay? In response to the lower cardiac output due to the lower contractility, your kidneys, as demonstrated up here, tend to retain fluid. And as they retain fluid, it's just like adding fluid to the vascular system. You get a parallel shift upward and to the right in your vascular function curve. So it's just like giving someone a transfusion. Remember, hemorrhage went this way. It was a parallel shift to the left and downward. This is adding fluid, so it's a parallel shift to the right and upward. Your operating point shifts upward and to the right. If it's moderate heart failure, you can actually get back to 5 liters per minute here on your cardiac output. I called that compensated failure. Uncompensated would be if you can't get back up to a normal cardiac output. That's what I'm calling uncompensated failure. And so you have a drop in cardiac output because the heart failure is so severe you can't get back up to 5. okay, no matter how much fluid you retain. And of course, this increases your central venous pressure, increases your capillary pressure, increases filtration relative to reabsorption. It makes your edema worse, okay? And that's why we go through this. We have Mr. Simmons being treated with carvedilol. So the first thing we asked you to do is fill out this table for metoprolol, which is a pure beta-1 blocker. Okay, so your beta-1 beta-1 antagonist will have its effect on two parameters, the heart rate and the inotropic state. And of the two, the heart rate is usually the one that dominates. And that was the one that I was really looking for you to go with as the initial change. When I ask this on an exam, there will be only one initial change because I don't want to sit down there and argue with you about which one is worse, the decrease in inotropic state or the decrease in heart rate. But in this case, that's really where I wanted you to start. Decreased heart rate, decreased cardiac output, decreased mean arterial pressure, increased central venous pressure, increased stroke volume, and your decrease in cardiac output limits the increase in stroke volume, okay? And that's how we came to the direct response. The reflex response is tricky because your beta-1 antagonist blocks some of the reflex response. So let's go through this. First, we have our total peripheral resistance reaction. Well, that's primarily the alpha receptors. The other receptors are there, but in a normal person, the alpha receptors tend to dominate in the system overall, and you tend to get vasoconstriction. So that's fine. You get an increase in total peripheral resistance, an increase in MAP. That's pretty much normal. Next, we go to heart rate. Well, you're blocking the beta receptors. So you're blocking any increase in heart rate that you would ordinarily get through the sympathetic nervous system, okay, at the SA node. However, you'll note here, I still have a small increase in heart rate. And that's because although the part of the baroreceptor reflex, which is an increase in sympathetic tone, is blocked, the parasympathetic tone is still falling. And when you get a fall in parasympathetic tone, which you will get as part of the baroreflex, you'll still get an increase in heart rate. It just won't be as big as it was if you had that sympathetic response going for you as well. So you'll get a small increase in heart rate, small increase in cardiac output, small decrease in central venous pressure, and a small decrease in stroke volume. Your inotropic state, it's the same thing. You have a sympathetic tone to your ventricular muscle, and that's being blocked. That increase in tone, the norepinephrine, the beta receptors are being blocked here, and it's blocking that response. So you might, and there's no parasympathetic output to the ventricles, at least nothing that has any physiological effect. But you'll notice I still have a slight increase here, and the reason I have a slight increase here is because although the ventricles only get sympathetic tone, the atria get both parasympathetic and sympathetic. And so I block the sympathetic at the ventricles and the atria, but the parasympathetic tone, the decrease in parasympathetic tone will still increase your inotropic state, your contractility a little bit in the atria. They'll cause a little bit of an increase in stroke volume, or a little bit of increased ejection of blood into the ventricle, and cause a little bit of an effect there. Now your stroke volume still falls, but nevertheless there is a little bit of an increase in the contractility because of this effect on the atria. So when we add them up, I've got steady state. One goes one way, one goes the other, but this is weak. We know it's weak, right? Because I just said it's atria only. So you go with the direct response here. The decrease in reflex response is small. The direct response is the increase is normal. So I go increase here. I go increase here for the same reason. The reflex response is small. I go decrease in heart rate because we have the small increase in heart rate in the reflex response. So I'm going to say the direct response dominates, which ordinarily it will anyway. But here we have good reason to believe that the reflex response is going to be smaller than normal. Your total peripheral resistance goes up because there's no change here and an increase here. Your mean arterial pressure always slightly in the direction of the direct response. So in the case of cardiac output, you could have even used your causal relationships, and that definitely tells you that you've got a drop here. With these others, I say you go with the direct response just like you normally would because these are small, okay? And our relationships will hold if you do that, all right? So that's our metoprolol. The only difference in the carvedilol table is that in addition to the changes in heart rate and entropic state, we're getting a vasodilatory response because we're blocking the alpha-1 receptors. So Mr. Simmons, I believe he has hypertension in his history. This might tend to decrease his hypertension overall if you're treating him with this as well. And it certainly tends to decrease the afterload, which will have a beneficial effect on the heart as well. So we have a decrease in total peripheral resistance in addition to these other effects, okay? And all this is the same, but now note that my increase in TPR here is relatively small. And the reason is because I'm blocking my alpha-1 receptors. Now my alpha-2 are still intact, so I'm saying you'll still get some vasoconstriction here, some increase in TPR, and some increase in MAP because of that, but it's going to be smaller than normal because your alpha-1 are going to be blocked. And so when you add them up here, you get the same results, but now, in addition to that, we have this small change in the total peripheral resistance. So you get a decrease in total peripheral resistance here instead of the increase that you got with metoprolol here, okay? Now it's a decrease because we have a decrease in the direct response. We have a weak reflex response, so you go with a decrease, and you have the decreased MAP here, okay? All right. And finally, we have our switcheroo. Mr. Simmons doesn't respond to therapy, so ultimately he's given digoxin. This is not given as often as it used to be, but sometimes I'm told in cases where it's particularly bad and the response to medical therapy isn't optimal, you might still prescribe digoxin. We go through it here because it is an excellent exercise to go through because it involves virtually every step in the excitation, contraction, coupling process. So I asked you for a concept map here. You have digitalis binding to the receptor. In this case, it binds and you decrease the sodium-potassium ATPase, okay? And that, if you decrease that function, you're not transporting out as much sodium as usual, so your sodium inside your cell goes up. If your sodium goes up inside your cell, then that means your sodium gradient across the membrane falls because you have a higher sodium inside. Outside, it's probably still normal, but your gradient falls, so that means you get less sodium-calcium exchange, which means you get less calcium efflux across the membrane during diastole, and therefore you get increased calcium during diastole because you get less removal across the SL. So that calcium, instead of going across the sarcolemma, is accumulated in the SR via the SR calcium pump, okay? So that increases your SR calcium content. That means that on the next beat during systole, you're going to get calcium influx across this membrane. It's going to bind to your release channels and trigger release, and you'll get more than the normal amount of release because you had more than normal amount of calcium in your sarcoplasmic reticulum. That increases calcium in the cytosol during systole, and that binds to your myofilaments, troponin C, and that causes an increased force of contraction. That causes an increase in stroke volume, and that causes an increase in cardiac output. All right, so that's my review for Keith Simmons. Thank you.